Right, so this is a pretty basic talk on the concept, complications, and trade-off of dual mobility. So this is an example of a case which I saw some years back, maybe 10 years back, where there was an trochanteric fracture which was addressed with a THR which dislocated, and somebody put in a constrained liner and the liner came out. So we have to understand this in a much better way nowadays in order to come out of the situation. So putting a constrained liner or dual mobility is not a bailout for poor surgery. So that's the first thing. So understand the head size considerations and impact. So we know that you have spinopelvic problem, you have so many problems, but the native hip never dislocates, right? Does it dislocate? No. But replaced hip, you are talking all about spinopelvic, this, that. Why doesn't the native hip dislocate? So something we don't get right, there is some issue still lacking in our own understanding. And some of it could be related to the effective joint space, because the head size which is being removed is not replaced. So even if you put a 36 millimeter head, there is still some space in that joint for it to dislocate. So if you have some other parameter like a poorly done surgery or a spinopelvic which is jeopardizing the normal spinopelvic movement and all that, then the hip is more prone for instability. So this thing we have to understand. Now the acetabular socket size, choice of bearing and minimum insert thickness must determine the head size used. That is the limitation of our modern bearings. So we cannot reduce the size of the polyethylene by 5.5 millimeters or lesser, and typically for safety we use about 8 millimeters diameter for the polyethylene. So that's a limitation of machining and engineering right now. Now again, in the wake of metal on metal failure, extreme caution must be used before using other large diameter hard on hard bearings or very thin cross-linked plastic. So we don't know what works. There is still some work going on. That's where resurfacing counts, because resurfacing, it's almost close to the native hip and it takes into account most of these parameters with respect to instability, and hopefully it will come through in the future. No changes have been made on the femoral side, but head sizes have been increased. So the biggest reason why the metal on metal failed was because of large diameter metal on metal hip replacements, not because of resurfacing per se, if you discount the poorer designs. And in the literature, there is no evidence to support the use of head size, but we still talk about dual mobility, instability and all this. So this is definitely not conclusive. Now, dual mobility is not a new concept. So it was introduced way back in 1979. So it combines the concepts of low friction arthroplasty of Charnley and the concept of using a large diameter head by Mecke and Farrar. So this was a French-based concept. So you have a cup which is put in, which is having a metal backing, highly polished surface. You have a femoral head which is of small diameter which articulates with the femoral stem, and you have a large polyethylene diameter which is articulating with this. And typically it looks like that. Current modern generation cups like the Biomentum have got a ceramic bearing with a highly cross-linked polyethylene which is available. So this takes into account some of the issues with it. You also have options of putting screws into this thing, although you have 4 different options with the previous cup as well. So you have a screwless option, you have a cemented option, you have an option for revision, and an option to put a screw as well, a single superior screw and 2 inferior screws with the dual mobility cups. And you have this modular metal liner type of devices which are more popular because it gives the surgeons the flexibility to put screws into different segments. But the challenge with this is the metallosis has been reported because of micro movement between this liner and the metal cup in itself. So that in itself is a challenge. So there is some question mark over how long these will last, whether there will be issues related to acetabular metallosis and related failures because of the metal reaction. So from what we have seen so far, dual mobility is promising because it tends to replicate the native head size. So it takes into account one of the most important factors. It takes the effective joint space a bit out of the equation, but still you have to get your component positioning right. Is it the answer for all the problems? Well, that we have to answer carefully. Where do you definitely use it? You can use it in patients with higher risk for instability, like a fracture neck femur in an elderly patient who is a community ambulator and you wish to choose a total hip replacement through one of the posterior based approaches. Then dual mobility is a reasonable solution. And although the literature doesn't support it, it makes sense to do it when you're doing a posterior approach based surgery. And this is how it will look like, a dual mobility cup. And you must be careful how you assemble this head into the socket. Usually you'll have a snap, and if you don't assemble it properly, then the assembly can disengage. And that's how it looks like. You have situations where there is a intertrochanteric fracture with pre-existing arthritis where you're planning for a hip replacement, or a failed proximal femoral nail type of situation with acetabular erosion where again you're planning to do a total hip arthroplasty. Then a dual mobility cup is an option if you're doing a posterior based approach. Again, I'm talking more and more about posterior based approaches, because if you do a direct anterior or a Harding approach, then most of the surgeons don't tend to use the dual mobility, because anterior based approaches, the stability seems to be better. Again, if you have any revision for instability, again you are looking at a dual mobility. If there is any sort of neuromuscular dysplasia, you're looking at dual mobility. If you have a revision situation, again the dual mobility is an option. And if you are revising for a proximal femoral resection, you have an abductor deficient situation, again dual mobility is the option of choice to begin with. Now the question is the dual mobility advantage real? We really don't know how large a diameter is big enough. There is some dislocation rate even with the dual mobility, so you don't eliminate dislocation completely by use of this, but it significantly brings down the dislocation rate in the high risk population. So definitely there is some merit to this use. And the dislocation is not the only concern, so you must look at long-term survivorship, how it will pan out in the long term, whether you're able to achieve press fit in all the cases. Some of these are osteoporotic, and if you have a cup without screw, are you really able to get a good press fit fixation with the uncemented socket? Is the metal backed cemented cup good enough? That's again questionable, because if you look at the literature and how the history has panned out, metal backed cemented cups don't do really well, so they just tend to pull out in the midterm because of various issues. And what about the revision? Is there any concern? And what are the problems related to dual mobility, if at all? Design related, unique to the implant. Can we use in young active patients? Salvage of failed implants, revision hip arthroplasty, and is there really enough evidence to support its use? So design related, there are multiple interfaces for wear. You have a large polyethylene surface which is articulating with the metal, so the chances of volumetric wear could theoretically be higher. The implications of use of conventional versus cross-linked versus vitamin E poly again have to be determined. So there is no clear-cut evidence, but if you use conventional polyethylene, then the risk of volumetric wear will definitely be higher. And if you look at the Australian Orthopedic Association, there is a unique complication of intraprosthetic dislocation. It does not avoid wear, osteolysis or aseptic loosening, and this needs to be watched carefully before you adapt it in the younger patients, because you are expecting higher wear on convex surfaces and greater wear in patients less than 50 years, and those operated for childhood diseases have been reported in the literature. So I see a lot of the patients nowadays asking that I want to sit on the floor, please do dual mobility. So they come and ask for dual mobility. I see a lot of young surgeons offering it to patients with avascular necrosis with no real risk factors for instability. They just offer a dual mobility hip replacement. I think that you must be careful about. Unique complications to the implant, intraprosthetic dislocation up to 5%, but these only become apparent at 8 to 10 years, so they don't happen overnight. It happens because of progressive polyethylene wear or the failure of the retentive mechanism, so that the head will come out or the liner comes out of the thing. So it's an intraprosthetic dislocation. So the head comes out while the polyethylene remains, or the entire thing can come out. So there are multiple modes of this particular thing, and this is how it typically looks like, where there is a bubble sign. You have the polyethylene there, and one part of the articulation is still remaining. And the challenge with this is when you try close reduction, you have this eccentric picture because the polyethylene has disengaged there. And you ask your junior to do a close reduction in the ER or in the OT, and you're not there, and you see this picture, they send it away, and it's an eccentrically located femoral head. And more often than not, if you have an intraprosthetic dislocation, you will require revision surgery. So how do you recognize this? Eccentric position of the femoral head. You have a characteristic bubble sign. You have three types of intraprosthetic dislocation. You have failure of retentive liner due to wear. You can have dislocation because of arthrofibrosis between the junctions, or you could have a loose cup as well. You can have metallosis, which has been reported with this particular thing. And you can minimize retentive failure by improving the configuration and finish of the femoral neck stem as well as the type of polyethylene. So if you have a ceramic bearing on a highly cross-linked polyethylene with a very well-finished neck, then the risk of retentive failure and wear is minimized over a long period of time. And we hope that the newer designs will address some of these issues. The take-home message, you must use it in patients with high risk for instability. Definitely it has a role because the dislocation rates with dual mobility are lower in these high-risk populations. But you must use it with caution in young patients due to lack of evidence and risk of some complications. So current use in my practice is limited to patients at higher risk for dislocation and elderly patients where you don't expect them to live for 30 or 35 years. Thank you.